Labor and childbirth are complex physiological processes driven by a coordinated interaction between maternal hormones, uterine muscles, the cervix, the pelvis, and the fetus. Although labor often appears sudden to the outside observer, it is the final outcome of weeks of biological preparation involving endocrine signaling, structural changes, and neurological feedback mechanisms. Understanding the physiology of labor helps explain why labor progresses normally in some women, becomes prolonged or obstructed in others, and why medical interventions such as induction, assisted delivery, or cesarean section may become necessary. The initiation of labor is not triggered by a single switch, but by a gradual shift in hormonal balance between the mother, placenta, and fetus. Throughout pregnancy, progesterone plays a dominant role in maintaining uterine relaxation and preventing premature contractions. As term approaches, the uterus becomes increasingly sensitive to contractile stimuli, even though progesterone levels do not dramatically fall in humans. Instead, there is a functional withdrawal of progesterone activity accompanied by rising estrogen influence. Estrogen increases the expression of oxytocin receptors on uterine muscle cells and promotes the formation of gap junctions between these cells, allowing contractions to become synchronized and effective. Oxytocin, produced by the hypothalamus and released from the posterior pituitary gland, is the primary hormone responsible for uterine contractions during labor. Its release is stimulated by cervical stretching and uterine activity, creating a positive feedback loop known as the Ferguson reflex. As the baby's head presses against the cervix, nerve impulses are sent to the brain, leading to increased oxytocin secretion, stronger contractions, and further cervical dilation. This self-reinforcing cycle continues until delivery occurs. Clinically, synthetic oxytocin is often administered to augment or induce labor when this natural process is insufficient. Prostaglandins also play a critical role in the physiology of labor. These lipid compounds are produced by the placenta, fetal membranes, and cervix, and are essential for cervical ripening. Cervical ripening refers to the softening, thinning, and increased elasticity of the cervix, which allows it to dilate during labor. Without adequate prostaglandin activity, the cervix remains firm and resistant, leading to prolonged or failed labor. For example, in post-term pregnancies or in women undergoing induction with an unfavorable cervix, prostaglandin medications are often used to initiate this physiological process artificially. The uterus itself is a powerful muscular organ composed primarily of smooth muscle fibers arranged in layers. During labor, these fibers contract in a coordinated pattern that begins at the fundus, or top of the uterus, and moves downward. This directional contraction is essential for pushing the fetus toward the cervix and birth canal. Each contraction causes temporary tightening of the uterine muscles, increasing intrauterine pressure and promoting cervical dilation and fetal descent. Between contractions, the uterus relaxes, allowing blood flow to the placenta and oxygen delivery to the fetus. Excessively strong or frequent contractions can compromise placental blood flow, leading to fetal distress, which is why continuous monitoring is often used in laboring women. The cervix plays a central mechanical role in childbirth. Throughout most of pregnancy, it remains long, firm, and closed, providing a protective barrier that helps prevent infection and preterm birth. As labor approaches, biochemical changes in collagen structure and water content make the cervix softer and more distensible. Effacement, or thinning of the cervix, usually precedes dilation, especially in first-time mothers. Dilation occurs as uterine contractions and fetal pressure gradually open the cervix to approximately 10 centimeters, the diameter required for the baby's head to pass through. Failure of the cervix to dilate despite strong contractions is a common reason for labor arrest and subsequent cesarean delivery. The fetus is not a passive participant in labor. Fetal positioning, head flexion, and descent are crucial determinants of successful vaginal birth. Ideally, the baby enters the pelvis in a head-down, face-back position known as occiput anterior. This position allows the smallest diameter of the fetal head to pass through the maternal pelvis. During labor, the fetal head undergoes a series of movements collectively known as the cardinal movements of labor, including engagement, descent, flexion, internal rotation, extension, restitution, and external rotation. These movements are necessary to navigate the curved and relatively narrow pelvic canal. Abnormal positions, such as occiput posterior or brow presentation, increase the mechanical difficulty of labor and are associated with prolonged labor, increased pain, and higher rates of operative delivery. The maternal pelvis provides the bony framework through which the baby must pass. Pelvic shape and dimensions vary among women and are influenced by genetics, nutrition during childhood, and overall skeletal development. While most pelvises can accommodate vaginal birth, certain pelvic configurations or mismatches between fetal size and pelvic capacity can result in cephalopelvic disproportion. This condition occurs when the fetal head is too large to pass through the maternal pelvis and is a classic indication for cesarean section. Importantly, this diagnosis is often made during labor rather than before, as pelvic flexibility and fetal molding can sometimes allow successful vaginal delivery, even when size discrepancies are suspected. Pain perception during labor is another important physiological aspect. Labor pain arises primarily from uterine contractions and cervical dilation in the first stage and from stretching of the vagina and perineum in the second stage. These pain signals are transmitted through different nerve pathways, which is why pain characteristics change as labor progresses. Psychological factors such as fear, anxiety, and previous traumatic experiences can amplify pain perception by increasing muscle tension and stress hormone release. Conversely, supportive environments, effective coping strategies, and pain management techniques, such as epidural anesthesia, can significantly alter the physiological stress response and improve labor outcomes. The progression of labor is traditionally divided into stages based on physiological changes. The first stage involves cervical dilation and is the longest stage. Efficient uterine contractions and cervical compliance are essential during this phase. The second stage involves active pushing and fetal expulsion, requiring coordinated maternal effort and adequate uterine force. The third stage involves placental separation and expulsion, a process driven by continued uterine contraction and retraction. Failure of the uterus to contract effectively during this stage can result in postpartum hemorrhage, underscoring the importance of uterine tone in safe childbirth. After delivery, the physiology of childbirth does not immediately end. The uterus continues to contract to compress blood vessels and prevent excessive bleeding. Hormonal shifts promote lactation, uterine involution, and emotional bonding. Oxytocin remains central during this period, facilitating both breastfeeding and maternal-infant attachment. Disruptions in these processes, such as uterine atony or hormonal imbalance, can lead to postpartum complications that require prompt medical attention. Labor and childbirth are the result of an intricate physiological orchestration involving hormones, muscles, nerves, and mechanical forces. Successful vaginal delivery depends on the alignment of uterine contractility, cervical readiness, fetal position, and pelvic capacity. When one or more of these elements is compromised, labor may deviate from its normal course, necessitating medical or surgical intervention. Understanding the physiology of labor not only clarifies why childbirth unfolds as it does, but also highlights the importance of individualized, medically informed decision-making to ensure the safety of both mother and child.